Health literacy, the ability to obtain, process, and understand basic health information needed to make appropriate health decisions, is alarmingly low in the United States, and this contributes significantly to health disparities and poor outcomes. AI has genuine potential to improve health literacy, but realizing this potential requires careful design and implementation. The current state of health literacy is dismal. Studies consistently show that a substantial portion of American adults struggle to understand health insurance documents, interpret medication labels, or comprehend basic health information from providers. This isn't primarily about intelligence, it's about how health information is typically presented using technical language, assuming background knowledge, and not accounting for different literacy levels or learning styles. AI's potential to address this problem stems from its ability to personalize explanations. Unlike static health education materials, AI can adapt explanations to individual comprehension levels, use culturally appropriate examples, translate medical jargon into plain language, and respond to follow-up questions that clarify misunderstandings. This responsiveness could help people truly understand health information rather than pretending to understand while remaining confused. Language translation is another powerful application. For the millions of Americans with limited English proficiency, health information is often inaccessible or requires inadequate translation services. AI with robust multilingual capabilities could provide health education in people's preferred languages, improving access to information that's currently limited to English speakers or those with access to human interpreters. Reading level adaptation means AI could explain the same health information at 5th grade, 8th grade, or college reading levels, depending on user needs. Health literacy varies enormously, and one-size-fits-all materials inevitably leave some people behind. AI that asks users what level of detail they want and adjusts accordingly could make health information accessible across the literacy spectrum. Visual explanations and analogies could supplement text-based information. AI could generate metaphors and examples that make complex health concepts concrete. Instead of technical explanations of blood pressure, AI might explain, think of blood pressure like water pressure in your home's pipes. Too low and water doesn't reach upper floors. Too high and pipes can burst. The right pressure keeps everything working without damage. Interactive learning could replace passive information consumption. Instead of reading a pamphlet about diabetes management, users could have conversations with AI that respond to their specific questions, correct misconceptions, and ensure comprehension through guided dialogue. This active engagement likely improves retention and understanding compared to traditional health education materials. However, significant obstacles prevent these potential benefits from automatically materializing. Accuracy across health topics is inconsistent with current AI. The system might explain diabetes accurately, but provide outdated or incorrect information about other conditions. Until AI achieves consistently high accuracy across all health topics, using it for health education creates risk of spreading misinformation along with useful information. Cultural context sensitivity requires extensive work. Health beliefs, communication preferences, and cultural frameworks for understanding illness vary enormously across populations. AI trained primarily on mainstream medical literature might provide explanations that don't resonate with or are actively offensive to some cultural groups. Ensuring AI health education is culturally appropriate requires diverse input in design and extensive testing across communities. Trust and adoption patterns matter enormously. If communities most in need of health literacy improvement are least likely to trust or use AI tools, the technology won't reduce disparities and might widen them. Older adults, low-income populations, and communities with historical reasons to distrust medical establishments might be skeptical of AI health education, regardless of its quality. Audit and verification processes are essential. AI health literacy tools need rigorous evaluation by health educators, medical professionals, and literacy experts before deployment. Regular audits should check that explanations remain accurate as medical knowledge evolves, and that AI hasn't developed incorrect responses through model drift. These quality control systems are expensive and time-consuming, but necessary for responsible deployment. Policy support could accelerate beneficial uses of AI for health literacy. Public funding for development and evaluation of AI health education tools would ensure they serve public health goals rather than just commercial interests. Integration of verified AI tools into school health education could reach young people while establishing patterns of informed AI use. Community health centers could receive resources to deploy AI health literacy tools with staff support that helps users understand how to use them effectively. Public AI literacy programs are themselves necessary. People need to understand what AI can and cannot do, how to evaluate AI-generated health information, when to seek human verification, and what limitations AI has. Without this meta-literacy about AI itself, people can't use AI health tools safely and effectively. Standards and certification for health education AI could provide quality assurance. Just as we have standards for textbooks and educational materials, we need standards for AI systems providing health education. Independent certification that a system meets accuracy, cultural appropriateness, and accessibility standards would help users identify trustworthy tools. The fundamental question is whether AI will reduce or exacerbate health literacy disparities. Technology has a history of initially benefiting already advantaged populations while lagging in serving those most in need. For AI to genuinely improve health literacy at a population level, particularly among groups with the lowest current health literacy, requires intentional design for equity, substantial investment in access and training, and ongoing evaluation to ensure benefits reach those who need them most. Without this focused effort, AI might improve health literacy for tech-savvy, higher-income populations while leaving vulnerable groups further behind.